Okay, great. I will get started. So, Dr. Kim, while you were talking about Dr. Evans, you reminded me of something that happened, and you shared your appreciation for his mentorship and expertise. And he's also very fond, very dear to my heart, because it just so happened that a patient that I treated with radiation ended up in his operating room for a Whipple. And this is an excerpt from his operative report. He says, I should mention that there was virtually no fibrosis following the patient's neoadjuvant therapy, and this patient's radiation therapy was obviously given with tremendous care and talent, as there was no fibrosis stemming from his neoadjuvant therapy. Clearly, his radiation therapy was beautifully delivered, and this is the most beautiful love note I've ever received from a surgeon or anybody. So
That's awesome.
He must be an outstanding individual. I haven't met him personally. Okay, so I do want to tell you all about radiation therapy tonight. Some of the things I was going to discuss, you already covered, Dr. Kim, so I will make those parts more brief. As you know, the role of radiation in pancreatic cancer has been debated for a long time and is still an area of active investigation. So I'm going to focus on a few things: improving the R0 resection rate, the effect on local control, as perhaps 30% or more of pancreas cancers are dominated by local progression as opposed to systemic disease. And just kind of say up front that there's really no evidence of a survival improvement just based on radiation therapy, except maybe some single institution data for dose escalation, which I'll get into. So radiation is best used in selected patients. The first consideration, I believe, as I think you do, Dr. Kim, is to achieve systemic control. And then RT is often done with the goal of optimizing surgery or being a second choice for local control. So I hope nobody is offended by the analogy that I'm about to make. But we have surgery, chemotherapy, and radiation therapy. And I would liken surgery to this Porsche. It is wonderful. It is perhaps the best benefit that we could give a patient, but unfortunately, it is not accessible to everybody, but only a small proportion. I would liken systemic therapy to this car. It is outstanding in its utility. It does a lot of things and is very useful, and it is accessible to a lot of people. And where does radiation therapy fit in? Well, like I said, it basically is an adjunct and a help to these other two. So here is radiation therapy, a killer sound system for whatever ride you are currently riding in. So first I'll talk about R0 resection rate. Here are some selected modern trials. These are mostly prospective trials evaluating the role of radiation therapy in potentially resectable, so either resectable or borderline resectable pancreatic adenocarcinoma. The first trial is the Dutch study, the PREOPANC trial, which was reported in manuscript form this year, and looked at 16 centers with 246 patients with resectable or borderline resectable disease. They received 3 cycles of those who were randomized to this arm received 3 cycles of neoadjuvant gemcitabine, and they got radiation therapy during the second cycle, a modest dose of radiation of 36 gray and 15 fractions. And then 4 additional cycles of gemcitabine after surgery. Those who went for upfront surgery got 6 cycles of adjuvant gemcitabine. And again, as was shared earlier, the median overall survival favored pre-op treatment in the intention to treat analysis. However, in those patients who did have surgery, there was a clear benefit to receiving neoadjuvant therapy as described. And the resection rate was not different, but not just different statistically, 61% in the pre-op treatment group and 72% in immediate surgery, and the R0 resection rate was much higher for those who had neoadjuvant treatment. Also, neoadjuvant treatment improved disease-free survival and local regional failure time. And here's the disease-free survival. There was also a Korean prospective randomized multi-center phase 2 and 3 trial reported a couple years ago in Annals of Surgery. They intended to enroll 110 patients. After about half of the patients had been enrolled, and some did not receive intended treatment. Some did not receive intended treatment, but 50 were analyzed with the primary endpoint of 2-year survival. They were randomized in this trial to 54 gray with gemcitabine prior to surgery or upfront surgery, followed by chemoradiation therapy. In this trial, the 2-year survival was much higher in neoadjuvant treatment, as was the median overall survival, and that was statistically significant. And the R0 resection rate on an intention to treat analysis was 51.8 versus 26.1. However, if you're looking at those who actually had surgery, so you're looking at R0 with the denominator being the ones who actually did have surgery, there was a dramatic improvement in the R0 resection rate. So this trial was terminated after half the patients were enrolled due to the clear benefit of neoadjuvant treatment. In talking about borderline resectable pancreatic cancer, this paper has been one that I've used for years. It's a retrospective review from MD Anderson, and they had a particular definition of borderline resectable. It could be borderline resectable because of anatomic consideration. In this paper, abutting the SMA, abutting or encasing a short segment of the common hepatic artery, occluding the SMV portal vein confluence with possible reconstruction. Or they could have indeterminate or questionable nodal or metastatic disease and be considered borderline resectable, or it could be due to performance status or medical comorbidity. Patients, and again, this is a retrospective review, but patients got chemotherapy that was gemcitabine based for 2 to 4 months, and then chemoradiation therapy, and then they were restaged 4 to 6 weeks post-therapy, and had a multidisciplinary evaluation prior to possible surgery. 160 of the patients in their database that were treated from 1999 to 2006 were analyzed, meaning they got this kind of treatment, and 125 completed pre-op therapy and restaging, and 66 underwent pancreatectomy. The ones who completed surgery, the particular definition of borderline resectable, 38% anatomic, 50% of them who were intermediate questionable metastatic disease, and 38% of those who were poor performance status. So all of the patients, whether their definition of being borderline was any of these, many of them did go to surgery. They had grossly negative margins in all patients, and the R0 resection rate of those going to surgery was 94%. Of those who received neoadjuvant treatment, not all went to surgery, so if you look at that group, it was 50%. And the partial pathologic response, meaning less than 50% of the remaining viable tumor cells were present, was 37 out of 66, or 56%. And a pathologic complete response was found in 6%. Major postoperative complications occurred in 20%, and there were 2 deaths. And the median survival of those resected was 40 months, and those unresected was 13 months. And you can see the benefit for resection in these patients. There was also recently a phase 2 trial from Michigan where the neoadjuvant chemotherapy was perhaps superior in that it used FOLFIRINOX, and that's why I present this trial, because there's less data in that space. They had FOLFIRINOX times 6 cycles and then radiation therapy to 50 gray and 25 fractions concurrent with gemcitabine, followed by 2 additional cycles of gemcitabine. And their primary endpoint was the rate of R0 resection with the alternate hypothesis of 55%. And of 25 enrolled patients, 84% completed FOLFIRINOX, 76% completed radiation, and 52% were resected, and all had an R0 resection. And for all comers, the progression-free survival was 13 months, and overall survival was 24 months. For those who had resection, progression-free survival was 21 months, and overall survival was 37 months. And here is the tumor response with, and this is again a pathologic response. So what Dr. Kim said about downstaging, this is not radiographic RECIST criteria, just their definition of the response as seen in the cells on pathology. And many had a partial response or stable disease, and only one had progression. So that's really, those were my thoughts for resectable and borderline resectable disease. Now we'll talk about unresectable, sometimes referred to as locally advanced, but more specifically unresectable disease. Here are some selected trials of chemoradiation therapy versus chemotherapy alone. In these trials, there's been a back and forth with some trials showing a benefit to adding chemoradiation versus chemotherapy alone. And here are some trials that looked at induction chemo plus or minus radiation therapy. And here I think we have some more compelling data for a good strategy for these patients who are not thought to be resectable and unlikely to ever be resectable. And that is that systemic control is really the primary objective. And then perhaps radiation therapy comes into the picture. So in an MD Anderson retrospective of 323 patients between 1993 and 2005, 247 received upfront chemoradiation therapy with concurrent 5-FU or gemcitabine, and 76 received a median of 2.5 months of induction gem-based chemo followed by chemoradiation therapy. So the median survival was improved with induction chemo compared to upfront chemoradiation therapy. And the median progression-free survival was also looked better. The median times to local and distant progression were improved with induction chemo as well. And there was no significant difference in the patterns of failure. So you obviously, with radiation's humble contribution to pancreatic cancer, you obviously don't lose anything by doing chemotherapy first. There was also a retrospective review of patients who were prospectively enrolled on GERCOR trials that was reported in the JCO in 2007. And patients had a minimum of 3 months of induction chemotherapy, and the decision to give chemoradiation therapy or continue chemo in patients without disease progression after chemo alone was left to the investigator. In this experience, 29% of the patients developed metastatic disease during induction chemo, and the progression-free survival was only 2 months with an overall survival of 4.5 months for those patients. So we benefit those patients by not jumping on a local therapy early. If there was no progression, then 72 patients were given chemoradiation therapy, which was 55 gray plus continuous infusion 5-FU. And 56 patients were given additional chemo. And the median progression-free survival was improved for those getting chemoradiation therapy. Again, this is, as was the overall survival, again, this is a retrospective analysis of some prospective data. There was also the LAP-7 trial, which was a randomized trial to assess whether administering chemoradiation therapy could increase overall survival in patients whose tumor is controlled after 4 months of induction gemcitabine. This trial was a 2-by-2 design that also investigated the role of erlotinib. Here's the schema for that study. You can see the first randomization is to erlotinib or not, and the second is more chemotherapy versus chemoradiation therapy to 54 gray. There was no difference in overall survival between the two groups of radiation or not. And the progression-free survival was trended towards an improvement with chemoradiation therapy, but the p-value was 0.06. So this trial stopped after a planned intermediate analysis. The tolerance of chemoradiation therapy was similar to chemo except for nausea, and the addition of erlotinib failed to improve survival and was associated with increased grade 3 hematologic, digestive, and skin toxicities. So another take home from this is that maybe more efficient systemic treatments may be needed to treat early micrometastatic spread and help have tumor response as opposed to gemcitabine alone. And that's kind of a big question for us radiation oncology. So does the value of radiation therapy increase or decrease with better systemic therapy? And my argument would be that it probably increases as we control micrometastatic disease better. Local control maybe becomes more important. That's not to say that systemic therapies don't provide local control, or there couldn't be a systemic therapy that rivals radiation in local control. So the last part of what I wanted to say today is just to talk about techniques in radiation therapy and give a little review of the difference between traditional 3D conformal radiation therapy on the left versus IMRT in the middle and SBRT on the right. You can see the blue is a low dose, and that's much more spread out in the 3D conformal and a little more tight in the IMRT, and we're still typically giving good margins around the tumor, so that red high dose is being treated to the tumor plus a pretty healthy margin around it. Whereas with SBRT on the right, you're really just targeting what you see as tumor, and then there's a sharp dose fall off around that. There's also the issue of how much dose are we actually giving. When you want to compare doses with different fractionation schedules, you have to do a calculation, a BED calculation, biologically effective dose. And these two would potentially be given to the same prescription, so they'd have the same BED of 59.5. The SBRT, which is typically given in 33 gray in 5 fractions, would have a pretty similar BED of 54.8. So even though you see the prescription dose being different, the BED is very similar. And then just for a reminder, here's the formula that we use to calculate the BED. So what about SBRT? So it does have some conveniences. It's convenient for patients because it takes 1.5 to 2 weeks instead of 5 or 6 weeks. It has good dose conformality, but IMRT can be similar. There's pretty low acute toxicity with SBRT, probably less nausea for patients compared to patients who are trudging through 6 weeks of treatment. And there's potentially less delay in proceeding with other therapies, but typically SBRT is not given concurrently with Xeloda or gemcitabine like long course radiation can be. And data suggests that SBRT does not compromise a potential surgery option and does not increase potential surgery complications. SBRT was recently looked at in an alliance trial. This trial's goal was to try to estimate the 18-month overall survival rate of patients with borderline resectable pancreatic cancer receiving either 8 cycles of FOLFIRINOX or 7 cycles of FOLFIRINOX followed by SBRT. Secondary objectives included the R0 resection rate and the event-free survival rate and pathologic complete responses. Unfortunately, after very few patients were enrolled, the SBRT arm was closed due to futility after an interim analysis showed that the R0 resection rate was less than 60% in those few patients. So that did not continue. So they felt, because of the way the trial was designed, they felt that SBRT was not being effective in helping reduce or improve the R0 resection rate compared to the FOLFIRINOX by itself. So that's one thing we can do is SBRT, and it's a good option for some patients. Another thing that we do and that we've incorporated on the SHAPER trial, which I'm getting to, is a simultaneous integrated boost, but also a simultaneous integrated protection. So a simultaneous integrated boost is taking part of your target and prescribing it to a higher dose, giving it a little more radiation every day, than the rest of your target. A simultaneous integrated protection, as I'll call it, is carving out from your target the areas that overlap with sensitive organs at risk, like the duodenum and stomach, and giving those areas that don't overlap a high dose, but keeping the areas that do overlap at a safer dose. So an MD Anderson series that included 47 patients treated with dose escalation gave patients a very high dose of radiation therapy, 70 gray and 28 fractions, and the BED for that is 87.5, so much higher than the 50 range, or 67.5 gray and 15 fractions with the BED of 97.9. Again, the regions of normal structures abutting the tumor or overlapping were treated with conventional doses of BED closer to 50. And in this analysis, they found that the overall survival improved when the BED was greater than 70. There were a variety of doses given. The degree of tumor coverage, so you're kind of worried that, okay, you're giving a higher dose, but you're really not even giving the higher dose to the entire tumor. In this analysis, the degree of tumor coverage did not correlate with the outcome, suggesting that dose escalation to even a part of the tumor could be of benefit. When you're doing a technique like this, it's important to have daily imaging. At Huntsman, we do have a diagnostic quality fan beam CT image guidance system in one of our vaults. The more typical onboard imaging is a cone beam CT, and if you've looked at the difference between those two kinds of CTs, there's really much more soft tissue definition in the diagnostic quality fan beam CTs. So that is an advantage that we have for daily image guidance for the pancreas, where there's so much different soft tissues with different radiation sensitivities. And it's important because the stomach can be bigger some days and smaller some days, so you'll have overlap that comes in and out while you're going through a course of radiation therapy. We can use inspiration breath hold to help keep the tumor still, or we can use free breathing and incorporate 4D CT planning to know the movement of the target and the organs at risk during treatment. So just a few words about the SHAPER trial. So it's a phase 1 study of losartan and hypofractionated radiation therapy after induction chemotherapy for borderline resectable or locally advanced pancreatic cancer. It's a phase 1 single-arm trial. We're really investigating 3 things, though. We're lucky to be able to cram it all into this trial. We're investigating the combination of losartan and radiation therapy and the safety of that combination. We're investigating using a hypofractionated higher dose radiation therapy, and we're investigating using volumes that are shaped, i.e. SHAPER, to avoid organs at risk, as I just described. So why are we looking at the combination of losartan and radiation therapy? Losartan, of course, inhibits the renin-angiotensin system and can reduce the activity of TGF-beta, which is associated with hypoxia and contributes to radioresistance. In mouse models, losartan extended survival of pancreatic mice with pancreatic cancer in association with diminished TGF-beta activation. And some outcome studies have shown that patients with pancreatic cancer that use ARBs had a significantly longer survival in just straight up, population studies. And so, and it's also believed that users of losartan or ARBs have a normalized extracellular matrix, therefore more oxygen can be delivered to the tumor, and radiation needs oxygen to work, and chemo also is aided by improved oxygenation. So why are we using moderate hypofractionation? Well, it's, in my mind, a good combination, a good middle ground between SBRT and long course radiation. SBRT is limited in delivering high BED radiation due to the surrounding tissue. Early studies showed high rates of duodenal toxicity with SBRT. And pancreatic cancers are poorly defined sometimes. So the small margins that we're able to use with SBRT raises the question of marginal miss. And we saw that the reproducibility of contouring a pancreatic tumor by a radiation oncologist is not very good. So often these tumors are very hard to define on cross-sectional imaging. to exactly where they extend to. And that's a challenge that we see in tumor boards as well in determining their vessel involvement and whether they're resectable. Standard fractionation is also maybe suboptimal because it's been used for decades with limited and contradicting success rates. And it maybe requires a longer time away from multi-agent chemotherapy, which could increase risks for distant metastases and progression. So that's why for this trial, we chose moderate hypofractionation, and we're doing that in conjunction with modern immobilization, imaging, and radiation delivery techniques. So we hope that this will allow the delivery of a high biologically effective dose without undue risk to surrounding normal structures. This is a radiation, part of a radiation plan from a patient treated on the trial, and you can see that the high dose is carved away from the normal structures of bowel and duodenum, and the low dose is allowed to overlap in order to cover the whole tumor. We use a particular set of dose constraints, and we have to meet all of these per protocol or with only one variation acceptable. Otherwise, we go down to a lower dose, and these are the doses that are allowed on the trial. The highest total dose that we could use is 67.5, which is the dose used in that MD Anderson paper, with a BED of 97.9. But if we don't meet all of the dose constraints for the normal organs, we go down to the next highest dose and down from there and down from there. These are the patients who've been treated on Shaper. You can see the neoadjuvant chemotherapy that they received. Most of them received FOLFIRINOX. All of these had what were considered unresectable tumors by vessel involvement. And the doses delivered range from 52.5 to 60. So none of them got that highest dose, but all of them got a BED higher than 70, which was what was shown in the MD Anderson paper to be effective. All of them have stable disease at this point. Some have gone back on chemo. One had surgery. So there's no clear signal in the data for a benefit of adjuvant radiation therapy, but I thought it would come up. So I'm just going to address it in a couple slides and then I'm done. I think adjuvant radiation therapy may be reasonable for R1 resections or lymph node positive cases. But it could also be held in reserve for local recurrence. I think in a lot of cases, chemotherapy is maybe, again, more important. There was a combined Hopkins and Mayo analysis of 794 patients from Hopkins and 478 at Mayo. They compared adjuvant chemoradiation to observation, of course, in patients who didn't get neoadjuvant treatment. And they did find a benefit for adjuvant chemoradiation therapy, but that hasn't been shown in every trial. Some do and some don't. Some show even negative results for radiation. So the oldest trials did show that chemoradiation therapy was better than no adjuvant treatment, and we know that now. We can't just do surgery alone. This SPEC trial had a 2x2 design. It showed that adjuvant chemo was helping, but adjuvant radiation therapy was not helping, maybe even hurting. This CONCO trial showed that adjuvant chemo can reduce local recurrences too, as you see that gemcitabine reduced local recurrences to 34% from 41%. I don't know if that was statistically significant, but the survival was. And but the local recurrence is likely even lower with radiation therapy. However, with the right chemotherapy, overall survival is pretty good without radiation therapy. So we often pass up on doing adjuvant radiation. The NCCN says that adjuvant therapy options are dependent on the response to neoadjuvant therapy and other clinical considerations. So I think that we do consider it and can use it in certain cases where further systemic therapy is not thought to be helpful for a particular patient or where there was an R1 resection. Okay, that's all I had. Thank you so much.